I'm just going to cut in real quick and give a little bit of a promo for myself and my crash course. This one is coming September 18th, 19th, and 20th. We're going to be live, online, virtual with me an hour a day. I know you can fit that in to understand how to navigate the hospital birth system. It is complicated. It is tough. Hospitals, nurses, doctors, we have our own birth plan for you. So how are you supposed to make sure that yours works? Join me. The hospital crash course, you're going to learn everything from getting admitted to birth, to recovery, to how to work with the nurses and what your rights and responsibilities are. Go to myfriendsandnurse.com/crash course to join and register today. All right, welcome to the 8th episode of the Birthlink podcast. How exciting. We're going to dive into episiotomies and we're going to do that in just a minute. I just wanted to come in real quick and say what's up, how my life is going. We are incorporated since like literally 2 days ago. So My Friends and Nurse Inc. So I'm going to be able to start doing a lot of things in the community now and start pushing through for the home health agency that I'm so excited to get started. This has been about 7 years in the making so that I can give licensed, skilled nursing care at home surrounding maternal and newborn care. So this is assessments, education, bilirubin lights, all of the stuff that we can do. What about NST testing? You guys got to go in twice a week to the hospital? No. I want to send a nurse to you. So that was what I am working on, and I'm really excited about that. The childbirth course, I think I have an ad going right now for that. That's on the 18th, 19th, and 20th. Please join me. It is a low-cost class. I have to charge because I need you guys to show up, and it's so important because these topics are rarely discussed in birth classes. I do have it in my membership and the Birthlink membership with clients and my full course, of course, but that's like 9 modules. It's quite an extensive course. Is that something you're interested? Colette at myfriendsandnurse.com and we'll get into it. We can have a little discovery call and maybe get you in as a client, and I can get you through the end of pregnancy and childbirth and even postpartum, non-scathed, feeling prepared, calm, confident, all of that stuff. And that's what I want for you. So today we'll talk about episiotomies and we'll continue with the first 15 series because this is it's really important to talk about. What are you asking and talking to your provider about? These are the things, this first 15, because it's going to be very hard for you to talk to them about it at the time of. So we'll get into the history of that. I'm still going once a week to the hospital and at the bedside laboring with women. There's 2 hospitals I go to and one's a lot smaller. I think it's going to be closing soon. Yeah, they're just, it's such a huge shame because it feels like a birth center that has an OR. So I love it. A lot of nurses don't like to go there because it doesn't have a NICU. So we would, as a labor and delivery nurses, we would have to step in and take care of the newborn until they got transferred. A little scary. So that's why I call it kind of a birth center. But I like it. I appreciate it. There's less medical interventions, but it's also not that busy. So then when I go to a hospital, a bigger hospital, like I did last week, that has resident doctors and attendings and fellows and a larger staff of nurses, it's just a little bit more routine on what they do to intervene in birth. They're really stepping in to check your cervix like every 4 hours, every 2 hours, even. Like once my patient got to 6 centimeters, they wanted to check her every hour, the doctor said, just to make sure she's making change. Like that's too much pressure every hour. And then he said, well, she's a risk for infection. So we really need her to make change or we're going to have to have a C-section. I said, so you're scared of having an infection. So that's why you're going to check her, but checking her is what causes the infection. What? I had to do too much with this one. Spoke to too many doctors, like how they all came into her room first thing in the morning. There's 5 doctors just standing in there. It's unacceptable, you guys. We can't treat our moms in labor like this. It broke my heart. It really did. I had to talk to them outside like that. Do you think that was appropriate to come in? Now the mom's shaking and scared. She's been doing this for 3 days. And now you're telling her like she needs to dilate in the next hour or she's going to have a C-section. And that's first thing in the morning with 5 doctors standing over her. It took me everything. It took everything in me to just not blow up. I was so upset. But that is why it's so important to protect your privacy in labor, right? Come to my workshop, come to a birth plan workshop where I can tell you how to do this, how to protect your space, how your partner needs to stand up and stop these doctors from coming in like this, and stop scaring you, and stop using these types of words that can get into your head. Like, why do you need the cervical exam every hour? If they could, they would have done it. Unfortunately, we had a quick sesh. I did a quick workshop with her and she was able to stall it an hour, like another 2 hours, which is great. But they were still coming in every 15 minutes to check, how's she doing? Are we increasing the Pitocin? Are we doing? It's leave her alone. Please let me do what I need to do to support her, get her position changed. Baby looks great. She has no fever. Ugh. Look, now I'm just ranting on this thing, but just come to the workshop, hear me out on what you can do to protect that space so you don't end up like that mama. All right. So let's do it. Let's get into episiotomies now. Welcome to the Birthling Podcast, presented by My Friend's a Nurse. I'm your host, Colette McCullicher, a high-risk labor and delivery nurse right here in sunny California. I'm also an OB certified specialist, birth educator, lactation expert, and mother of 2 beautiful daughters. I am passionate about guiding you through the miraculous journey of pregnancy and childbirth, using evidence and history and asking the reason why. I have some incredible medical friends and colleagues, and we're all here to help you navigate this often overwhelming birthing hospital system in the United States. My goal is to gain trust in birth, improve this system, and provide some valuable insights. Let's make this journey a little less daunting and a lot more joyful. Let's get into it. Childbirth isn't easy. Okay, we all know this. But according to mostly men over the last 300 years or longer, it's a shock that it's even possible to happen at all. I love getting into the history of why we do what we do in labor and delivery and birth at the hospital, but I have to dive in one day and just study like the entire history of birth from the beginning of time. It's just so fascinating. And I guess I am doing this little by little. We'll have a series on the history of pain management, of C-sections, and surgical assisted vaginal deliveries, among other things. But today we're going to dive in for a bit on the history of episiotomies. This is part of the first 15 series. Even though it's technically happens before the baby is born, it does happen in the very end of the second stage of labor while you're pushing, with hopes that baby's going to come out in a few seconds. So this is a discussion that has to be had with your provider before you go into labor, during your prenatal visits, to have an understanding on their view of this significant intervention before there's a need. So the whole idea of the first 15 is that you're going to be in such a fog after labor that, or immediately before it, that you're not going to be able to have these insightful conversations and participate in true shared decision making. So that's why I'm including episiotomies. And most likely I'll add vacuum and forceps deliveries as well in this series. There's just so much, and we'll get into that later. But anyways, this has to happen with your provider. When they need to do it, it's usually not a conversation. Like, they don't even mention it so many times that they're doing it. It's crazy. And most of the times mom's numb-ish with an epidural. So she's not even going to be aware that it's happening. They may be aware, but it happens very quickly, right? Or they're going to know right away if they feel anything. And then doctor will make sure that they're numb first and they're not feeling anything. But usually in the throes of this birth coming, it's maybe a few sentences, if that. I have seen a handful of times that the OB lets the mother know that she needs to make a small incision to allow the baby to come out, and the mom agrees because there's just not a lot of thought that can be had in that moment. It's like, Like, she's not saying like, well, what is the real reason behind this small incision? What are the risks? What's the recovery going to be like? What happens if I refuse? Like, none of this is going to be discussed in that moment. So to be fully empowered over your body and your care and your baby and your birth, this is an important convo that needs to be had. Everything I want to discuss in the first 15 is around topics like that. That's going to be tough to discuss appropriately while you're either delivering or having your baby, or it's a few minutes old on top of you. Super important that we do this. We'll add the vacuum and forceps, skin to skin. We'll do stimulation of your baby, applying a hat. Even that's a decision. Do you want them to put a hat on your baby? Is it necessary? Why are they doing it? Understand even the little nuances. Why not? This is your birth. If you just want to go and have them do everything to you and to your baby, okay, but it's a bit of a scary thought from the things that I've seen. So understand everything. What about baby medications? What about postpartum Pitocin? I want to get into that next time, postpartum Pitocin and delivering your placenta. It's not always just cut and dry, you guys. There's things that you need to know. Are you going to keep your placenta? What happens when you want to take it home and then they say, oh, we can't, or they forget it there because you didn't have a proper conversation? What about when we move your baby over to the warmer for urgent care? Do you understand why we're doing that and what's involved? Yeah, these are all part of the first 15. So today, episiotomies. What is it exactly? Well, it is a small incision in the perineum tissue. That's the area from your vaginal opening all the way down to your rectum. That's a perineum. And they're going to cut just a little bit at the top, making that vaginal opening bigger, right? That perineum around the vaginal opening is stretching tight as baby's coming out. And if it's not stretching fast enough or they feel it's just too tight, they're going to snip it open for you. There's actually 4 types of episiotomies, but the 2 most popular, at least here in the US and the UK, are the midline. That one goes right down, 6 p.m., all the way down like a zipper opening up to your rectum. And the mediolateral, that one is more like a 7 p.m., like 7 to 8 p.m. position on the clock, like off to the side. And those 2 have their pros and cons to each, right? So each provider who is performing this procedure is going to have their favorites on which way they want to do it. Some will choose the midline because it's easier to suture and it looks nicer. Some will go off to a mediolateral because it prevents less damage, less bleeding. So why snip it at all? Well, we talked about it a little bit. It's the perineum needs to stretch, right? It needs to open. Sometimes it needs to tear to some extent to allow the baby to pass. Well, before it was thought that it could, if you just cut a little incision, it's going to prevent a 3rd and 4th degrees tear, like a really, really bad one that goes all the way to your rectum. So if the doctor thought that perineum was too tight, the baby was too big, and they needed to get their hands in there to help bring the baby out or use instruments, then that incision would be really helpful instead of a big old tear as they tried to do all these things or have a big baby come out and tear you all up. Not a lot of faith in the women's body, especially if they're progressing very quickly. Many things we do in the hospital then, so you understand, are preventative, right? The hospital and the provider, your doctor, is assigning the risk and applying their own tolerance, tolerance, and making the quick decision to intervene for you most of the time. And we need to have an understanding, like, is this a valid though? This their opinion and their experience to cut. What are they believing? What are their values? Why are they choosing to do this intervention while so many others are not? They may believe that the incision would heal better than the natural tear. They used to think that, well, it looks pretty. It looks prettier than an all jagged up tear. So we'll just do a nice clean incision and that just looks so much better. And it's easier to repair as well. So why not? They also thought that it was going to help preserve the muscles and connective tissue that support the pelvic floor, right? So prevent tearing, improve healing, and preserve the pelvic floor, all solid reasons, right? But none have been proven valid today. So let's get into the history of it. Originally, it was performed by Sir Fielding Ould. That's O-U-L-D. He was a midwife and a doctor. He was Irish, I believe, and he came from a family of doctors and military guys, and he advocated for the procedure in a book in 1742, so 280 years ago. The book was called Treatise of Midwifery in 3 parts. And he thought that when the vaginal opening was too tight, it could dangerously prolong labor and delivery. So he said, we need to get this baby out quicker. Let's help by opening up the birth canal a little bit more. It's just a perineum, right? It's not the whole canal. Anyways, the first report of the procedure in the US was 110 years later in a journal where a medial lateral episiotomy was used to facilitate an unusually difficult labor. So it's still not routine. In fact, they were probably just like, this is really taking forever and this baby's stuck and perineum is too tight. What can we do? And they're like, I read this treatise from 1742. What was it? 1742. Yeah, I got it right. Let's try an incision. So they're going to try anything, right? Sometimes in those kinds of situations, trying something is better than nothing, right? So in 1915, there was a survey through the mail of prominent obstetricians, and that indicated that only a few of them used these episiotomies routinely at that point. So it's the turn of the century. They started using it in the 1800s, like 1850s, and he's like, oh, we got to do this. And then, as one starts, they get more confident and they start using it more and more. But still, in turn of the century in the 1900s, still not routine. So only case by case as needed, right? This is midwifery. A lot of deliveries were happening at home. So they weren't jumping to medical interventions as quickly. But what happened in the 1920s? Well, we know from previous podcasts with the cord clamping that there was a huge shift to hospital deliveries, right? And this is going to increase operative deliveries and procedures. By about 20 years later, in 1938, there was a doctor named Diethelm. I think I'm saying that right. Diethelm. Well, he asserted that the indications for episiotomy were well established and needed no defense. So he's like, leave it alone. It's helping. We're moving things along quickly. It's going to prevent less tearing, and just let us do our thing in the hospital, and we're here to help. So it was all about their desire to maximize mom's comfort, maternal comfort, and safety. They wanted to improve fetal outcomes, right? Instead of keeping a baby stuck in the birth canal that they felt it was suffering or causing brain damage, to get it out quicker. So they just wanted to help the babies, help the moms, make it more comfortable. They didn't want her pushing for hours and hours. If they could just speed things along. And usually that incorporated forceps to help speed it along, because just cutting usually is not going to do it all by itself. And yeah, so they just wanted to help the delivery process. And this was a time that technical interventions and hospital deliveries were just so popular and growing. Another reason why episiotomies became so popular in the 1900s and this 20th century was due to the support of a doctor named Joseph Dilly. In 1921, Dilly published a paper entitled The Prophylactic Forceps Operation. Remember I told you the forceps, this kind of goes hand in hand. Here he recommended the use of forceps with a medial lateral, so off that 7 p.m., episiotomy, which he believed saved the fetal brain from injury, preserved the integrity of the pelvic floor, and restored the birth canal to near perfect. So like I said, it was a prettier incision. And he said, we could just sew it right up and it looks so much better than this jagged tear that these moms are having, I suppose, with the forceps. Oh my gosh. Oh, no, no, no. So yeah, if you're getting forceps, maybe a little bit of an incision would be better than jamming forceps in to a pair. Anyways, sorry, going off topic. Anyways, this man though, DeLee, he believed that labor was a disease producing situation. And let me quote this right here. He said, it's decidedly pathological process. Historically, physicians have been trained to intervene in disease processes, including protecting the mother from morbidity of the birthing process. It was on this basis that numerous modalities to support the perineum, as well as to incise it, so cut it, have been described. So he believed that basically doctors could eliminate pushing and the second stage of labor by using forceps and an incision to basically reach in and pull the baby out. All right. Look, there's crazier ideas out there, but we'll just focus on this right now. To doctors at this time, it wasn't crazy. It was revolutionary. Some great ideas need to be studied for like 100 years before everyone says like, oops, never mind. So they thought it was genius. Moms don't have to push as long. We're just going to go in and pull the baby out, right? So it caught on. And it was basically routine in the next 20 years. By the 1940s in the US, everyone was doing it all the time. So if they need to go in and reach in and get it, and even when they didn't, they were cutting. By the 1960s, UK adopted the trend. Well, thankfully now there is this evolving division between birth, like being a dominant surgical model. That's the one in the US that we're really focused on by delivering in the hospital. And this new re-emerging social model of perineal care, right? So it's not just birth, but perineal care. Are we hands off? Or are we actively managing how the baby's coming out? It's both things are coming up now in society. I think a lot of it has to do with social media and education and shared decision making, like shared thoughts in a sense, with how quickly we can talk and converse and come up with ideas. So I'm glad. I'm glad this is happening. In fact, researching this episode, I found a lot of conflicting education depending on what website I was looking at. So evidence just didn't stand up over time. And in fact, it was proving to contribute to worsening tearing that would have happened naturally. Okay, did you hear me? So you make an incision, it's like opening the zipper or like tearing a piece of fabric, then that fabric is probably just going to keep tearing more. Oops, they didn't think of that one. Yeah, and then more evidence was showing that it actually injured the pelvic floor, not saved it. The perineum is still a bit of an anomaly of the body. Like it's this lacing of tissue and muscle woven together, like almost like a fan spreading out through our pelvic floor that's holding up and giving support to all our abdominal contents, right? So cutting through this fabric in a clean incision actually makes healing more difficult than the jagged natural tear. Imagine cutting through a piece of fabric, right? Like I said, you're going to be cutting on who knows what grain, any grain you like, because those scissors are sharp. You can just go nice and clean. But what did you do to the actual fabric? While if you just tear that fabric, it's going to tear easier along the grain and make it for an easier repair. Okay. So compared with a natural tear, the episiotomy is generally also more painful, especially during recovery, and it leads to greater blood loss and it takes longer to heal. So this is what the evidence is showing. But then when you do go on maybe hospital websites and you like a Mayo Clinic and issues like this, they're going to actually give you the indications of why episiotomies are recommended, right? And some of these are kind of against this evidence base that we're looking at. So they're going to support doctors choosing to make that decision, but not routinely. It's really nowadays just not routine. And you need to make sure you speak to your provider and ask them if they routinely do episiotomies, because then they're in the more old school type of thinking, right? Other risks associated with episiotomies, besides the pain and increased blood loss and taking longer to heal, is just like if you got a natural tear, there's a possibility of infection. And for some, it causes pain during sex in months following delivery. So we have learned, and then also the pelvic injury in the pelvic floor, and it doesn't hold up with all of the benefits that we showed, like speeding up the second stage of labor. Like, how is that helping? So yeah, so we've learned that cutting down the line, that midline incision, could actually cause more serious perineal trauma than when the cut extends, like I said, like that zipper that keeps going. If it extends to the anus, to the rectum area and the muscle there and the sphincter, that's called a fourth degree tear. That could risk a fetal incontinence and gas incontinence. I should laugh. Sorry. It's awful. Awful. No one wants to see a fourth degree, please. Please. There's other things that you can do to prevent that than an incision. And actually, an incision could increase your chances of that. Okay. There was a systematic review using severe vaginal and perineal trauma as the primary outcome. So that severe perineal tear, and it showed no evidence to support a policy of routine episiotomy. So doing it to everyone is not helping anything. You have to do it case by case, very restrictive. The author stated that there was a need to properly evaluate whether the midline or the medial lateral techniques provided the best outcomes. So it's not showing any evidence for doing this to every woman is substantial at all. And now they want to say, well, when you do need to do it, which one would be better, the midline or medial lateral? And the jury is still out. There's just like pros and cons to each one. So it's definitely a provider's preference. Okay, so it may not actually prevent bad tears, right? It may be actually the culprit for them. So what about shortening the time we push, right? That's in the beginning. They're like, let's shorten the second stage of pushing. Mom doesn't want to push so much. I hear so often women who have been pushing an hour or longer ask me if the doctor could just come and do something to speed this up. I'm sure back in the day, this was asked as well. And the doctor thought, let me see. Maybe there is something we can do. And that's probably how it all began, right? I would love to be a fly on the wall. Like shortening the second stage, which is the pushing, would not just give relief to a tired mom, but a baby, especially premature, who could get distressed quite easily, like easier than a full-term baby. And that could be a huge win, right? Other possible indications to shorten the pushing time include significant maternal cardiac disease or a history of stroke, anything that is going to cause additional internal intra-abdominal pressure. Like we need to get on with it, right? Even they thought a breech presentation that needed more space was an appropriate reason. So they have a list of reasons why they think episiotomy should be used. And to this day, they're going to use these kinds of reasons. So take note, because if any of those reasons could still hold up for your doctor, many were just trained in this intervention or that have experience using this procedure with success. So of course, they're going to keep coming back and using it. So you want to investigate this beneficial effect of shortening the delivery time. But when I did, it kind of got lost in studies of large populations of normal individuals, lower risk, in which the length of the second stage made little difference at all. So it's shortening the pushing didn't help with admitting to NICU or APGAR scores. Remember we talked about the APGAR scores? If you didn't hear that one, go out. I think that was like my first podcast. So APGAR scores, didn't do anything. And then they did a retrospective analysis. So looking back, and they also couldn't show any evidence of improving the low APGAR scores or NICU admissions. So I don't know if they went and asked their moms if they had improved exhaustion rates, right? And they're like, just get this baby out. So, hey, that might be a benefit if they think it's going to work. But again, to really speed it up, You have to think this baby is going through this birth canal underneath this pelvis bone. There's a lot more going on than just the stretched perineum, because once the baby is ready to deliver, that perineum is going to get out of the way. But if the doctor needs to go in and manually help the baby come out, maybe with an instrument like forceps, then yes, it's going to be an increase, and they need increased space, and they're going to give an episiotomy. And it didn't show any improvement. And it just depends case by case. How bad is this baby doing? How quickly do they need it out? I've seen doctors use forceps very successfully. So you need to talk to your doctor. Experienced ones are going to be your best friends and possibly save you or your baby's life. Right? Okay. So what about shoulder dystocia? I want to know this as a nurse, because this is one that we see a lot, that the doctor needs to get their hand in there to perform maneuvers to help get the shoulder underneath the pelvic bone. And sometimes that involves needs that snip to get the doctor's hand in to help assist. Right? So this is a very common reason. And I used to tell my patients this is a reason why a doctor would cut. And it is. But is it valid? Is it a reason they should cut? It seems like increasing the perineal space would help, right? Managing a shoulder dystocia by allowing more room. But it just wasn't proven. It wasn't proven to improve the outcome of injury to the baby. Despite this, it is still proposed and recommended by so many trained physicians and in practice guidelines in hospitals and through ACOG to allow additional maneuvers. So speak to your doctor about it. If episiotomy is just something you don't want, but then you are higher risk for shoulder dystocia, ask them, like, would you need to give me an incision if something happened? And their answers are going to be very telling of how quickly they're willing to do an episiotomy. Okay, so we are now moving to more restrictive episiotomy policies now with all of this evidence, which is great. We're finding a number of benefits compared to just a routine use. There's less posterior perineal trauma. So posterior means like the back, right? So the back end from the vagina to your anus, less trauma in that area, which is significant. That's where most of the tears occur and where most of the episiotomies occur. So when they're not doing it as frequently, less damage to that area, besides just trying to prevent it and cutting anyways. You might tear, so let's go ahead and cut you. Ooh, I don't know about that. Like, maybe she's just only going to tear like a first degree or a little vaginal, or like they're really trying to do their best to manage and foresee the future, and they're going to cut. It's a significant procedure. Like I said, there's no difference when they were like, so it was less posterior perineal trauma, less suturing then because less cutting, probably less perineal tearing, and then less suturing. So less time having to repair, right? So fewer complications in general when they just use restrictive. There's no difference when it came to pain measures and severe vaginal or perineal trauma. So the pain, like trauma to the vagina or the whole perineal space, there's no difference if you're going to use episiotomy or not. I had to do a podcast on this big old word, didn't I? Oh my gosh. Take a sip of water real quick. The objective of the whole point of having the doctor between our legs, right? And delivering us in a hospital, right there, it says right there. Why is it right there? Especially with our legs up in stirrups like that. It's to help guide the baby out and at best prevent perineal lesions. So the best way to do that, if you're lying on your back, is the way you are birthing, right? It's by manually supporting control of how fast the baby's head and body are coming out. If they're just going to pop out really fast, then that's going to create a large tear. They don't need an episiotomy to do that. They just need to help put a little pressure on the perineal space to help support it instead of it just like letting loose. Does that make sense? Manually, literally with their hand. There's no benefit to an episiotomy in a normal delivery or even in many special cases, just like a breech delivery or shoulder dystocia. They're just not finding evidence for any of it. So using an instrument in delivery such as forceps, okay, so that's one. If I really don't see doctors using forceps anymore that often, I swear. But if they did, that comes with its own risks. But this is where an incision to allow more room for the instrument may be necessary. It's all about the training of the provider. It's the training of the doctor or the midwife. That's going to be the most important thing when you're talking about protecting a woman's perineum. So what can you do? Well, bring up the topic with your provider ahead of time during your prenatal visits, right? We're not saying episiotomy or an incision, it's like surgery. We're not saying surgery is evil and absolutely no, right? There are cases that it is needed and could help you. So discuss those with the doctor. Is it routinely done or is it very, very subjective, right? Look, for me, it was never discussed. Not even before or not during. He never brought up needing to do an episiotomy, but it turned out he did it on everyone, right? This was after 20 minutes of pushing, and I was only 20 years old, and it was 23 years ago. And he just went ahead and snipped. I don't know why. He didn't discuss it with me. He didn't let me consent to it. It just needed to be done. The whole birth for me was just done to me. I didn't have too much say over anything. So when you bring up the topic, ask what their percentage is or how many they have done in the last 10 vaginal deliveries if they don't know their percentage, right? Oh, I don't know how much. Some of them do, right? But if they don't, then just ask them like, okay, in the last 10 vaginal deliveries, how many did you do? That'll give you your percentage. Do they find them useful? Or what is their take on them? Opinions can be very different from one provider to another. The current rate is about 4 to 5% of vaginal deliveries in the US. But I've recently heard a provider in Florida say that he cut 70% of his deliveries. So that is pretty routine. The other ones, he probably just didn't even have a chance to, didn't need to, or it was like their 5th baby. It's going to be very important to evaluate then your opinion on the matter and share that with them. They need to know where you stand as well and what your concerns are. It doesn't need to be something that is a scary situation with more understanding, right? And then having your voice heard. I'm all about that, right? I'm all about that in my workshops and in my birthing class and my membership. All my clients know you need to have a voice. And the only way you're going to have one is by asking questions and educating yourself. Put it in your birth plan. Just put no episiotomy. I'm all about like, no. Let them work for it. Let them explain why they really need it. And then you can consent, right? It doesn't matter if you're like, whatever, I don't care about it. Just put no or open to it, whatever you need. But it has to be a conversation. Being prepared and educated is very important, but so is having an open mind, right? So remember that it takes time for the perineum to stretch and give before the baby is born. But in some cases, the baby may not have that kind of time. There are very rare cases, according to current evidence. So it's very rare for that to happen, but it happens, right? So you got to be open-minded as well. Have the conversations and have a good understanding, and it'll be okay. So when is it more likely then that you could have one? Like, what are your chances? All right, so I found this information. If it's your first baby, and these are just like, this is a general idea of who is more at risk for episiotomies, right? Besides those that don't bring it up and never talk and never find out that their doctor does it 70% of the time, it's your first baby, your body, because your body hasn't stretched like this before. And some doctors, some providers don't have time for that. So sorry. Needing forceps or vacuum. Forceps, like I said, is a dying art. And we'll go into that maybe in a couple of weeks. And the vacuum, it doesn't need one. but it's still common for some reason to have an episiotomy with it. It's your doctor's discretion. If you agree to a vacuum delivery, then you can always ask your OB to avoid an episiotomy if possible. So you're also at higher risk of an episiotomy if your pushing stage is super long, so a couple of hours or more. If you have an epidural, if you're delivering on your back, especially with your legs in stirrups, if your baby is very big or the baby's head is in a abnormal position, so it's all tweaked to the side or looking up, sunny side up. And surprisingly, having a private, well, it's not surprising to me, but I was interested to see it on the list. Having a private obstetrician as your care provider also will increase your chances because they'll just do things their way and they're not so set on like hospital standards. So even though the hospital may be restricting, private doctors will do what they want. All right. So what lowers your chances then? So that increases your chances. What lowers your chances? Well, this is your second or more baby. You give birth in a side lying or upright position, that you've been massaging your perineum regularly in the late stages of pregnancy. That can help stretch things out quicker when the time comes. Your pelvic floor is super relaxed during labor. So you practice breath work, like that deep breathing and relaxing your jaw and your pelvis. And you've been stretching and not perineum stretching, but just stretching in general. And that's going to help your pelvic floor relax so that it can stretch out, keeping yourself in a good mindset. Your birth and your baby's head is happening more slowly. Like the head is coming out even between contractions. It's just guiding out. It's not popping out really fast. That's going to increase your risk. If you deliver at home or at a birth center, definitely your chances are going to go down that you're going to have that done. Or if you have a midwife or just really good support. And I feel like that good support comes with you as leading that support, asking those right questions, getting educated, talking to your provider. If you're continuing to speak to them about why you would do an episiotomy, why would it be needed for me? In what situations do you do it? Do you do this normally? I really would like to avoid an episiotomy and I want to consent to it before it's done. Is that all okay? If you're like bringing this up in conversation in your prenatal appointments, you're going to be on their radar as someone that they're not going to probably do an episiotomy as routine as they may usually with someone that never brought it up. Does that make sense? And this goes for a lot of stuff, you guys. If you want questions to ask your OB besides episiotomy, I have a list of them. Just message me, Colette at myfriendsandnurse.com, and I will send that over to you. No problem. Yeah. So bring it up. So there you go. With what has been called, this episiotomy has been called the unkindest cut or the slightest snip. That's how I heard. So 2 different ways to view this. And that's why I really wanted to dive in on it. Like, why is it not a big deal 20 years ago? Everyone's doing it. But now it's like, oh my God, they're cutting your vagina open. You have to educate yourself on what exactly it means and why they would need to do it and what your provider thinks and does. Because at the end of their day, they're the ones with the scissors. Okay. One of my favorites, Dr. Chopra, he has a podcast as well. He likes to always say medicine moves fast because he has these clinical pearls, these updates every week, and I love it. It's new things are coming out every week from ACOG and even A1, the nursing organization, or the Pediatric Association. Just things are, as experts learn, more data comes up. It takes maybe 100 years for it to all collected for them to be like, okay, we'll change it. And then all of a sudden they're changing it. So for these doctors that have been practicing, maybe they've started 30 years ago and it was routine. And then 10 years in, they're like, hey, we're going to change it. And they're like, what? we did it this way. Now we just need to change. So then he says that to actually change things in medicine, so the culture of the hospital and of doctors that have been trained, it's like moving a ship. It's like changing a ship's direction. Like, okay, we get it. Takes a quick second to push that button and post the recommendation now. but how long does it take to change the course of how we do things in the hospital? It takes a while. It does. So even in some parts, episiotomies have become less routine and more restrictive, maybe 5%. But then there's some doctors that are still doing it like 70% of the time, right? So as we dive into the history, this is just clearly evident of things like cord blood clamping and ships. Like, this is taking 100 years for us to get it together, right? So it could feel very quick, but 10 or 15 years later, recommendations from the board and expert directors switch, even though it took hundreds of years of practice to get there. So before you agree to anything, vote on it or put it in your birth plan, knowing the full history and current evidence. It's going to help you. It's going to help in your discussion and your decision making. Only going by what one provider's opinion may be is dangerous and it's limiting. Always dig deeper, which is why I'm doing what I'm doing and why you're here listening to this. So thank you so much. Next time on the first 15, we'll dive more into delivering the placenta and what your options are using Pitocin right after delivery. It's a super common and routine intervention currently, but why? All right. Thank you guys for listening. All right. I hope that was easy to follow and understand when I'm going into the history of these things and current evidence and practice. That's the idea. But I can go off on tangents sometimes, and I'm working on it. Okay, still new to this podcast scenario and how I work on it. If you want a more structured course, you can come to the childbirth crash course that we're doing on the 18th, or if you're listening before then. Or come and join me in my membership, the BirthLink membership. Love to have you. Clients of any gestation and wherever you are in your pregnancy, I can help you get the birth that you want and that you deserve. So join me next week for a great interview and with an excellent expert. I'm not sure who it's going to be yet. Production is looking at the recordings that we have, and we're going to pick a good one and post it next week on Monday. So join me then. Following that, we will get back into the first 15. Thank you for listening to My Friends and Nurse presents the BirthLink podcast. We hope you enjoyed today's episode and found it valuable. Before we go, a quick reminder. The information shared on this podcast is for educational purposes only and should not be considered medical advice. Always consult with your healthcare provider for any medical concerns or questions. If you enjoyed the episode, please subscribe, leave a review, and share it with your friends. Your support helps us reach more people and continue to bring you great content. Until next time, stay healthy and stay informed.